like to welcome my good friend, Andrew Yee from Mass General, who's going to be talking to us about emerging therapies in myeloma. Please be sure to laugh at his jokes.
Thank you, Betsy, and I'd like to thank the organizers and Total Health and the sponsors for inviting me and for helping to make this wonderful event happen. So I can't believe it's taken all this morning to get to the main event, which is to talk about multiple myeloma, right? Right? Obviously, I mean, all right, maybe there might be some, some fans out there, but I know, because I think we spent all this time talking about lymphoma, leukemia, but now we're going to talk about myeloma for a change of pace. All right, these are my disclosures. And, when I think about, so my task was to talk about emerging therapies in 15 minutes, and I'd like just to take a step in a different direction. We can talk a little bit briefly about the therapies that have emerged, and we have to think about therapies that were emerging, but now they're like fully emerged. So I think about, 4-drug regimens in multiple myeloma. We think about the anti-BCMA bispecific antibodies, the anti-GPRC D5D, talquetamab, as well as the CAR T-cell therapies. At one point, they were emerging, but now I think they're fully fleshed out and emerged. And then I had all these different emerging therapies I could choose from, right? And it's kind of a daunting list, like which ones do I pick? And to take it to the next level, instead of emerging therapies, we can even talk about submerging therapies. That was supposed to be kind of funny, but obviously it's falling flat. But I think, or a pun, but I think it is an important concept to think about, because as we heard earlier today from Dr. Jain about, in CLL, there's, a fixed duration of therapy as being important. And I think the next wave in myeloma therapy will be to identify a fixed duration of therapy, therapies where we can have a fixed duration using MRD to better guide therapy. But that's for a different time. So I'm just going to, for the interest of time, I'll just talk about these topics which revolve around BCMA. First topic would be belantamab mafodotin. So just as a refresher, belantamab mafodotin is an antibody drug conjugate that takes the naked antibody belantamab and combines it with the toxin mafodotin. Now this is different than vedotin. This is mafodotin. And you might be scratching your heads thinking, look, didn't I hear about this drug before? Is it some kind of one-hit wonder or something? Because it received accelerated approval in 2020, and then 2022 just disappeared, right? And then why am I talking about it again? Well, I'm talking about it again because it's one of the emerging therapies. So just to provide some background is the DREAM2 study, which led to the approval of belantamab mafodotin. So this is a study that looked at triple-class exposed patients, and as a single agent, it showed an overall response rate of about 31%. Now, I know in the context of other therapies, it sounds relatively modest, but again, this was as a single agent. And I just wanted to provide some background in terms of some of these other studies. Like if you think about like daratumumab, back then daratumumab and isatuximab showed an overall response rate of around 30% in patients who were primarily lenalidomide or bortezomib exposed. But then belantamab mafodotin, interestingly, in DREAM1 showed a response rate of 60% in a similar patient population, suggesting that belantamab mafodotin, if you target BCMA, has a little bit more, has some potential extra juice to it. So belantamab mafodotin received accelerated approval in 2020, but there was the DREAM3 study, and in DREAM3, belantamab mafodotin received accelerated approval in 2020, but you have to do the confirmatory study to a phase 3 to confirm the findings. So in DREAM3, it randomized patients to belamaf versus pomalidomide dexamethasone, and while while numerically the progression-free survival was better, it was not statistically significant. So because DREAM3 did not reach its primary endpoint, the drug was essentially withdrawn from the market in 2022. But then, okay, all right, so does anybody recognize this movie? All right, okay. I think some people didn't recognize the movie. Okay, actually, why do I show this scene from Shawshank Redemption? So essentially, there are a couple of other examples in the myeloma field. I'm sure leukemia, in other disease settings we have other examples, but DREAM3 is a negative study, so the withdrawal was approval with withdrawal. I know I'm speaking really fast because only 15 minutes, but maybe I should slow it down a little bit, right, Betsy? Okay. But, and then, Ocean, again, similarly, was a negative study. So, but I like to think of this, I showed this thing because I think about it as, we can think of it as the Bellamaf redemption, right? Because it turns out that they had 2 randomized, do you guys remember the scene? Well, actually, I feel bad because I'm giving away the movie now. But there's a scene, right, where this is the scene where he's escaping the prison. And that's because there are 2 randomized phase 3 studies which showed pretty significantly positive results. So based on the results of DREAM 7 and potentially DREAM 8, we potentially may see this drug back on the market and approved in the summer of 2025. Okay. So, and there we go. Okay, all right, thank you. So, so to talk about DREAM 7, a lot of myeloma trials, they're sort of rigged where you know that the investigational arm is going to win because you have like 3 versus 2 or 4 versus 3. So of course, if you have more drugs, generally speaking, the majority of the time, you're going to have a better outcome. But I think what makes DREAM 7 unique is it's a head-to-head. You guys recognize this movie?
Rocky 4.
Oh, okay. Whoa, Betsy, that was, and I didn't even give Betsy, I didn't even prime Betsy on this one.
Yeah.
Right? So, yeah, Rocky 4, the mid-1980s. Okay. So again, it's a head-to-head study. Most companies, they want to take the conservative, do 4 versus 3 versus 3 versus 2. But I give the company credit for doing a head-to-head mono-a-mono study. So we have the same background of bortezomib and dexamethasone, but then we're directly comparing belamaf, mafodotin with daratumumab. So in DREAM 7, combines belamaf, bortezomib, dexamethasone versus daratumumab, bortezomib, dexamethasone, and this is for patients with 1 prior line of therapy. And then after completion of 8 cycles, you go on to receive it as monotherapy. Now, the key finding here is that you can see kind of a whopping PFS benefit of about 37 months versus 13 months. Again, a direct head-to-head comparison. You see significant improvement in progression-free survival. And similarly, you also see this also corresponds with deepening responses, including MRD-negative responses. Now, we'll point out that in this study, this patient population was a little bit not your typical patient population because half of patients were lenalidomide naive. Now, in the US patient population, virtually everybody has lenalidomide exposure. But in the lenalidomide refractory subset, again, you do see significant improvement in PFS. And not only do you see improvement overall, let's look at the high-risk subsets. So the patients with high-risk cytogenetics, like say 414, 14, 16, or deletion 17p, these are traditionally the hardest to treat patients. And what is really impressive to see is that this drug can potentially overcome high-risk cytogenetics. And then, moreover, DREAM 7 showed improvement in overall survival. So again, an impressive, and I think to be able to show improvement in overall survival is a high bar to clear, at least in myeloma, because a lot of our myeloma therapies, to take, for example, like the anti-CD38 antibodies. The anti-CD38 antibodies have been one of the core foundational drugs that we use in myeloma. But interestingly, in relapsed disease with pomalidomide and carfilzomib, it turns out that you haven't actually seen a statistically significant overall survival improvement. So I think this just illustrates the power of targeting BCMA. However, DREAM 7 and the other studies using belantamab mafodotin, I think the major limitation with belantamab mafodotin is the ocular toxicity. And it's not because of BCMA. I think there's probably something intrinsic to the payload of using mafodotin. So mafodotin, actually turns out there are other drugs which use mafodotin as the payload, which also show corneal toxicities. And with belantamab mafodotin, the majority of patients will have blurry vision, but at the same time, nearly all patients will have recovery of the blurry vision. So I know that's perceived as a potential obstacle, but I think with appropriate education and supportive care, I think it will be key to be more effectively deploying this drug in practice. So then, in addition to DREAM 7, there's also DREAM 8. And DREAM 8, again, was another study, again, another randomized study of a triplet versus a triplet. In this case, is belantamab mafodotin, pomalidomide dexamethasone versus Pomvel dex. And again, this was including one prior line of therapy, and it had to include lenalidomide. And in that study, we also showed significant improvement in progression-free survival. So I spend all this time talking about, because this is a drug that could potentially be back on the market and available for use. So I'm just thinking for people in the audience who see patients, this is something that could be available to use. And for these other therapies, like for that, like CAR T-cell therapy or bispecific antibodies, the belantamab mafodotin is relatively easier to deploy in that you can give in the community. You don't have to worry about risk of CRS and neurotoxicity. I mean, for a CAR T-cell therapy, you don't have to, you have to go to like a major medical center like MD Anderson or et cetera, right? But this is something that could potentially be more convenient for patients closer to where they live. Now, another theme to emphasize is that, in DREAMM-7 and DREAMM-8, the doses of belantamab mafodotin that they use, they're like the approved doses, so to speak, right? So when you hear about this drug, they're going to talk about using it at 2.5 every 3 weeks. But I think the theme, something to emphasize, that in myeloma therapy, the drugs, and this is true for other disease types, the dosing that was initially presented isn't the dose that's actually used in current practice. So we see multiple examples of this. Like we went from twice a week IV Velcade to once a week Velcade, and Betsy played a pivotal role in the RVD Light study, for example. But the point is that with better dose modifications, you can reduce the risk of toxicity. So I think the anticipation is that if this drug were to be available and you were to use it in combinations, I would suggest think about using at a lower dose. Think about, instead of every 3 weeks, every 4 weeks, give it every 8 weeks, or even you can space out even further. So because when you're giving it in combinations, you don't necessarily need to use the dose as tightly together at such a high dose. Okay, so we spent a lot of time talking about CAR T cells, lymphoma, leukemia, and of course in myeloma we have 2 CAR T cell products approved. And recently in April, there was a recent update to the approval. So for ide-cel was approved in patients with 2 prior lines of therapy, and then for cilta-cel, it was for 1 prior line of therapy, which significantly expands the potential pool of patients who may be eligible for a CAR T-cell therapy. And this is a pretty busy table, but this was just to show in the initial pivotal studies, with ide-cel or cilta-cel, with cilta-cel in patients who've had a median of 6 prior lines of therapy, you could see an amazing PFS of 34.9 months. Now, I was just thinking about lymphoma, but we think of lymphoma and CAR T like it's supposed to be OMG, but I realized that PFS, oh my God, but PFS in lymphoma, it's not 34 months, though. It's like around 6 months, right? So I think there's a difference, but I know the lymphoma people will respond back to me and say, well, in lymphoma, the PFS, there's actually a plateau in the curve, so where presumably patients could be cured, whereas in myeloma, you don't see that plateau in the curve, so that's a fair response back. But with those amazing responses in patients who've had a median of 6 prior lines of therapy, why not try using it in patients earlier in their disease setting when potentially their lymphocytes could be healthier and the patients themselves could be in better shape to tolerate the potential toxicities of therapy. So we have the CARTITUDE-4 study, which looked at patients with 1 to 3 prior lines of therapy, including a proteasome inhibitor, and they had to be lenalidomide refractory. And I think what was really impressive to see in CARTITUDE-4 was a significant PFS benefit, hazard ratio of 0.29. And the separation is pretty substantial. Now, one potential thing to think about would be, okay, what about the control arm? Was the control arm something that you would use in your practice? So you use Darapom dex or pomalidomide Velcade dex. And what if you use carfilzomib instead as a potential? So I just want to point this out that, for example, in Leukemia, in the combination of isatuximab, carfilzomib, and dexamethasone, the PFS was about 36 months. Granted, they weren't 100% lenalidomide refractory. Now, what was impressive to see was they recently showed updated data from CARTITUDE-4 showing significant improvement in overall survival. So again, I was talking about how overall survival is a high bar to clear. So we can see with using cilta-cel in this patient population showed improvement in overall survival. Now, I think what was interesting to see was, this was across the whole CARTITUDE-4 patient population. And what percentage of patients have had prior daratumumab? Right, because in current practice, now that we have Perseus, Cepheus, MRAS, GMG, and MGHD7, using anti-CD38 antibodies moving to the front line. So in current practice in 2025 moving forward, the majority and more patients will have CD30 antibody exposure. So here, just wanted to point out that in patients who are triple class exposed, the PFS, it wasn't 35 months. It's only around 21 to 24 months. And for me, this has always been kind of a head scratcher. How do you go from 35 months and 6 median prior lines to something shorter? And I wonder if there's something different about a patient who's triple class exposed after only 1 to 3 prior lines, suggests that that patient might have a different type of disease that might be more aggressive. Now, something to point out with using CAR T-cell therapy, we hear about CRS, we hear about ICANS, but there is something, that might be relatively unique to myeloma CAR T cells and potentially more specific with cilta-cel is this delayed neurotoxicity. And I think in particular is this Parkinson's. So about 5% of patients in the cilta-cel had Parkinson's, and when that shows up, it's a major showstopper in terms of patients have personality changes, gait instability, difficulties with gait. And on the other hand, CARD2-4 is only a small proportion, only 0.6%. So there's probably something different about the different patient populations. Maybe we're better about using bridging therapy, reducing high burden disease. But I just wanted to share that as another emerging therapy is that we're also getting potentially better at treating this toxicity. So I just wanted to, this was actually something from our institution. And actually, this was actually my patient. So my patient had, around day 20, had personality changes. His gait, he used to be a really, very jovial person, but after the treatment, you can see his personality kind of made these subtle changes, and his gait started to resemble more like Parkinson's. And with that treatment, and then he got 2 grams he got a pulse of cyclophosphamide. And with a pulse of cyclophosphamide, that completely mitigated the Parkinsonism. And when I talked to him a couple months ago, 2 years, actually it was maybe earlier, maybe last month, gait changes his Parkinsonism respond, he remains free of disease. So I just bring this up as, the Parkinsonism is a major adverse event to reconcile with cilta-cel, but we have better ways of coping with it. And then there are 2 randomized studies to better look at cilta-cel in newly diagnosed patients. So these trials are ongoing. So I just want to conclude so I just want to talk about BCMA bispecific antibodies. So people talk about cross-trial comparisons, and people always say, don't like to do cross-trial comparisons, but personally, I love doing cross-trial comparisons because these therapies, they don't occur in a vacuum, right? It's not like you're going to compare the meal you had at one restaurant with the meal you had at a different restaurant, right? It's only obvious. But at the same time, I realized with these cross-trial comparisons, so I'm not sure if you guys remember this episode, like Homer Simpson loves Duff beer, right? And he goes to this temple, like the factory. And the guy there is talking about all the different beer varieties. But it turns out it's all coming from the same spigot, right? It's all the same thing. So we spent all this time talking about the differences between one therapy versus another therapy, but in reality, they're probably more similar than different. So, and I bring that up because I think we have 2 anti-BCMA bispecific antibodies, and now we were just hearing about the BCMA bispecifics and lymphoma. But they share common themes where, you have a PFS of about 1 year, but generally speaking, you have CRS rates of around 60%, and about 20 to 30% patients are managed with tocilizumab, and there is a relatively high degree of infections when you target BCMA. So due to the risk of CRS and neurotoxicity, there is this step-up dosing for these 2 where they're talking about required to be in the hospital, and you have to do this gradual step-up process. Now, what does the efficacy of having a PFS of about 1 year or more mean? So if you do this real-world comparison, you can see that it represents a significant benefit compared to the choices you would have available at the time. And then there are 2 other anti-BCMA bispecifics that are currently in development, and these are something to be aware of. And I think some things to point out is that linvoseltamab, the PFS of 12 months of 70% is probably the highest we've seen. And then with AbbVie's ABBV-383, one distinguishing feature about this is that there's no stepped-up dosing, and the dosing is about once every 4 weeks, right? With the other bispecific antibodies, it's about once a week. So with infection, when you target BCMA is on the surface of plasma cells. There's a lot of hypogammaglobulinemia. And BCMA is not only on plasma cells, it's on other cells upstream of plasma cells. So infection is very common. So when we think about teclistamab, they had a really high rate in MajesTEC-1 where, over 50% of patients had grade 3 to 4 infection, and there were over 10% death rates from infection. But if you think about when the study was done, it was done in 2020, and something else also was going on in 2020, right? It was COVID, right? So the majority of patients, they didn't have their, this vaccines weren't available, et cetera, and you can imagine that in 2025, when when COVID-19, there's near universal exposure and our vaccination to it, it's probably less of an issue. So in real-world practice, it's significantly less. And key to making sure that, I think a key thing to point out is using IVIG is key to the success of using anti-BCMA bispecific. So this is just one example from in Amsterdam. And moreover, so this kind of summarizes, we're using IVIG is key, as well as prophylaxis for VZV and PJP. Now, spacing out dosing is also another emerging practice. And here we can see, I think one thing we appreciate is we're using bispecific antibodies is how durable the responses can be, and that affords you the ability to space out the dosing. And moreover, so in February it was just approved that you can space out the dosing, but moreover, when you space out the dosing, you also reduce the risk of infection as well. And another thing that recently emerged from the ASH is that what happens if you have this longer interval between patients, right? If you go into every 2 weeks, every 4 weeks, what happens if you're 2 months out? Do you have to restart all over again? So it turns out that when this was looked at, the risk of CRS is very low. So they just updated the dosing where you have a 9-week interval. You don't have to restart from scratch. And then how do we make this more user-friendly? Because is the notion of using tocilizumab as prophylaxis. So instead of reacting to it, you can use it as prophylaxis. And presumably this could help with outpatient initiation of bispecific antibodies because you really reduce the risk of CRS. So one example, it was only like 14% as opposed to 60%. And so this was just in the NCCN guidelines. So I just have 2 more slides left. Okay. So one is in just a couple. So this is in relapsed patients, 4 prior lines of therapy. But now we can think about newly diagnosed patients. So here I just want to show just whopping responses. Look at the impressive progression-free survival. And then also when you look at combining in transplant-eligible patients or with bortezomib, you can see practically 100% MRD negativity rate. And this is only after 3 cycles of treatment, as opposed to, in the Perseus study, which looked at DAR-RVD after stem cell transplant, the MRD negativity rate was 60% after all that. And whereas if you just do using a bispecific antibody after 3 cycles, you have an MRD negative, which I think is, so I think in the future, this could be the next standard of care. So I think I spent a lot of time talking about belantamab mafodotin. I think this is something that can become available. I think using combinations will be key. I think CAR T cells are going to be moving forward, as well as anti-BCMA bispecific antibodies. I think the future looks bright, and I'm excited to see what the future unfolds. And sorry, I probably spent too much time explaining the jokes. Thank you, guys.
Thank you very much, Dr. Lee. Very entertaining. I'd like to welcome now Dr. Naveen Pemmaraju to the stage to discuss updates in myeloproliferative neoplasm. Dr. Pemmaraju, thank you.
Thank you, Dr. Kadia, and to the organizers of Total Health. Hello, Vail. Let's do this, okay? We're about to enter into a new golden era of the MPNs, and you've been sleeping on it, and that's why I was invited here to enlighten all of you. Myeloproliferative neoplasms, a chronic disease that becomes a very acute, life-threatening blood cancer in many of our patients. For many of you who are not seeing the MPNs, the reason why it's relevant to you is that this is a new golden era of drug development. I put a quick selection here for you, which is really to show you that some of these older diseases, polycythemia vera is undergoing multiple drug therapy trials, which I'll show you, and even essential thrombocytosis and the more rare MPNs of systemic mastocytosis and the 8p11 syndrome. In myelofibrosis, which is the majority of my talk, there are some new drug combinations moving beyond JAK. We're focusing on the anemia of myelofibrosis and completely novel agents beyond JAK, including telomerase and other targets. So let's take a survey of this. Polycythemia vera, an old disease, Osler's disease. All of you have known it since medical school and beyond. But what's important is, in addition to teaching folks to rule out secondary polycythemia, so renal cell cancer, erythrocytosis from other origins, smoking, once you get to PV, the standards, as you know, have been hydroxyurea and interferon. Those are okay, but we're trying to go for a new era of disease modification. And so there are new formulations of interferon, ropeg interferon in particular, which are FDA approved here in the States. And then the recent approval of ruxolitinib in the past several years has been added to the armamentarium. The other interesting thing is that there's new drug development, HDAC inhibitors and other drugs, hepcidin mimetics, that have come into this field and were highlighted at the ASH meeting. So the ruxolitinib, which is FDA approved initially for intermediate to high-risk myelofibrosis and also carries an approval for GVHD, is also now approved in polycythemia vera, intolerant or resistant to hydroxyurea therapy. So this old disease now has a new therapy. It's almost 100% of the time mutated with the JAK2 V617F, but the ruxolitinib is a JAK1/2 inhibitor which inhibits through the wild type pathway. So all these patients, whether mutated or not throughout the MPNs, can benefit. This is the MAGIC study led by Claire Harrison in the UK, an ingenious study which actually is investigator initiated. All patients had had hydrea before, go on to ruxolitinib, and for the first time in our field, it showed that the JAK inhibitor was superior to best available therapy for not only CR and duration of CR, but for the very first time, EFS and OS, the patients who had maximum benefit actually had allele burden reduction. We are nowhere near Dr. Cortez and CML on this, but we're getting there for the very first time. Second exciting agent that I'm a part of the development is that of rusfertide, or PTG-300, which is a hepcidin mimetic or modulator, which has opened up a new area of drug development, and there's 4 or 5 drugs active in this space. This positive trial was known as the phase 2 REVIVE study, in which we took patients who were phlebotomy dependent. So you had to have 3 or more phlebotomies over the prior 6 months to get onto the study. And there were patients who were allowed to stay on their active agent, but still having a suboptimal response. Of course, the goal of therapy for PV is to make sure your hematocrit is below 45%. So in this phase 2 REVIVE study, the primary endpoint was met, which was again to become phlebotomy-free, as compared to the other study group here, as you can see. But more importantly than the phlebotomy-free achievement, it's a weekly sub-Q injection, is that patients were able to stay on for quite some time, years now, and actually in terms of safety, outside of a mild skin reaction in some of the injections initially, overall well tolerated. These patients are expected to have thrombotic events, and so we did see some of those throughout the disease course. And so this is now with the phase 2 positive study, we've now moved into a randomized phase 3 control with this hepcidin mimetic, rusfertide, versus best available therapy. This is the phase 3 study, which is ongoing, and I'm proud to share with you that the phase 2 was actually published in New England Journal recently, again, showing that for the first time in the field, you have something that can completely replace the phlebotomy. So we actively await the phase 3, hoping to go for approval. So now moving to myelofibrosis for the remainder of the talk, the main area of investigation in our field. To level set, there are 4 approved JAK inhibitors. The first one, as I mentioned to you, was ruxolitinib, led by our colleagues Dr. Verstovsek and Harrison, approved now almost a decade and a half ago. Ruxolitinib first in class, Comfort 1 and 2 studies in New England Journal. And this has actually been really the longest running JAK inhibitor in the field. After that, we had the approval of fedratinib, approved in August of 2019, the second in class JAK inhibitor. Interestingly, all these JAK inhibitors have other targets. So this one has FLT3 and other activity, bromodomain and MYC as well. This was also approved in intermediate to high risk. Then we had the third approval, pacritinib, approved in February of 2020. And this drug was specifically approved for myelofibrosis with platelets less than 50. So representing the first time regulatory pharma partnership for a very specific niche area of unmet medical need. The fourth of these JAK inhibitors is momelotinib, which actually was a sea change approval just in 2023, September, which was for myelofibrosis with anemia. I mentioned earlier that's an urgent unmet medical need in our field. So with that background in mind, this is the kind of comfort one for ruxolitinib kind of benchmarks that we use, frontline untreated patients with myelofibrosis. Important to remember these numbers. So it was 42% what we call SVR35, so spleen volume reduction, 35% by imaging at 24 weeks. That became the gold standard in the field. And the second endpoint, which is usually carried as TSS, total symptom score, at week 24. Usually we like to see a 50% reduction, and that was around 46% in RUX. These trials compared against placebo, as I'm showing you here, as well as best available therapy. The reason why I wanted to make sure that you have that background is that although the JAK inhibitors led by RUX have been a revolutionary change in the field, the first targeted therapy approved class, these drugs largely do not cure. This is a disease that the only curative modality remains allogeneic stem cell transplant. If you get into the relapse refractory setting, let's suppose in the front line your survival was measured in decades, it can actually be 2 years or less. So this was a paper by our colleague Dr. Palandri in Italy, which showed kind of shockingly that at 3 years, in a series of over 218 patients, almost half the patients are off their JAK inhibitor, almost always for bad reasons. Side effects, complications, infections, progression of disease or spleen. Only a few of those patients actually going to a transplant. In multivariable analysis, the only thing that factored into greater overall survival after this happened was getting onto a clinical trial or having an investigational agent. So with that in mind, we led a group to write a white paper on this, and the term is now called disease modification. Can we move beyond hydroxyurea and just managing counts and blood transfusions to maybe put forward a three-pronged approach? Intervene earlier, potentially intervene with combinations, so more than a monotherapy, and then intervene with drugs beyond the JAK-STAT pathway. And I think that's why I mentioned that this is a golden era of drug development. These are just some of the main combination therapies. I led the study with my group for the BCL-XL navitoclax. Ultimately did not get FDA approved, but we were able to go to randomized phase 3 showing a 2 times improvement of the SVR35, the main primary endpoint, but alas, the symptoms were not improved, so therefore not FDA approved. The same fate with the pelabresib, bromodomain or BET inhibitor, randomized phase 3 study, SVR significantly positive, but the symptoms did not quite hit. And so it raises the question, when you add a second drug, can you still improve the symptoms from JAK inhibitor monotherapy? And I think we're losing good drugs because we have not yet changed our endpoints. The 2 remaining in phase 3 are the ones at the bottom, MDM2 inhibitor with navtemadlin, and kind of surprisingly for many of you in lymphoma, myeloma, Dr. Yee, is selinexor at a markedly lower dose than what you guys used, 40, 60 milligrams PO weekly, has now entered into randomized phase 3 studies. And again, this novel agent, this is from our group, this actually has to be wildly updated. We thought we included everything from there, but everything from CD123, CALR mutated, so surface attack, immunotherapy for the first time in our field, intracellular targets, and of course borrowing from AML and MDS, which you'll hear more from Dr. Daver. So a quick survey of some of these novel agents. This is work based on from Dr. Kadia from our group, who led the first ever Treg cells to be given to patients with myelofibrosis. And this is now in a next phase trial led by my colleague, Dr. Masarova. In this ingenious study, you have regulatory T cells, which we know can suppress inflammation, and therefore, given from an umbilical cord blood non-matched source, can it then restore hematopoiesis and even improve symptoms and reduce spleens. Early on, this is the first 10 patients that were shown as an ASH oral presentation. Not only you had reduction in spleen and symptoms, but you also had correlation with TGF-beta levels, which was part of the hypothesis for this new. So we've entered into immunotherapy for patients with MF. The second trial highlighted at ASH by our colleague, Dr. Mascarenhas, is that of navtemadlin. I mentioned the MDM2 inhibitor. This is in the relapse refractory post-JAK inhibitor failure. The concept is that MDM2 overexpression prevents p53-driven apoptosis in these MF stem cells. What I think is amazing about this agent, this is oral, again, non-JAK, a new pathway. You have to be TP53 wild type for these drugs. Large study, 183 patients, randomized either navtemadlin to best available therapy. And again, although it's modest, this is relapse refractory setting, so not frontline. You do see in patients treated, especially here with the waterfall plot, SVR35 and TSS50 being achieved in this relapse refractory setting in which the overall survival is estimated usually at 2 years or less. Disease modification, our new mantra, we are seeing a reduction in the VAF and bone marrow fibrosis, and this drug is now an active phase 3 trial in the frontline setting, suboptimal. Safety, this class of drugs, MDM2, has always been associated with GI side effects, so you do have to watch out for that, particularly given selinexor, this drug, and others, all of which have pretty serious GI effects in a chronic disease where you're giving double oral therapy. And this is the phase 3 that I mentioned, a very ambitious, very proud to see this trial, 600 patient trial planned, which is you're already on your JAK inhibitor ruxolitinib and you add in this new drug, the MDM2 inhibitor for suboptimal responders. Another exciting drug presented by Claire Harrison is the elritercept. Some of you may know this drug from the MDS space. This is CARE 050. The aim here is to improve especially the blood counts, the anemia, due to ineffective hematopoiesis through the TGF-beta superfamily. So this is in the same class of drugs of other TGF-beta before. What's amazing about this trial, what we were all surprised and happy to see among the first 80 patients treated either as monotherapy or with the JAK inhibitor, is in addition to anemia improvement and being a safe drug, we're also seeing improvements in spleen size. So this is already having early signs of disease modification. Let's see if this continues into the later stage studies. But this is one to keep our eye on, helping all areas of myelofibrosis, anemia, spleen, and symptoms. Just a quick comment for the rare MPNs, that's where I spend a lot of my time. There's this rare entity, the 8p11 syndrome. Most of you haven't heard of it because we've been missing it. It's been hiding in plain sight. It's an FGFR overexpressing tumor. Can you believe already one FDA-approved drug for this, pemigatinib, which is also co-approved for cholangiocarcinoma, same pathway. But it leads to deep cytogenetic and molecular responses, actually an acute deadly leukemia to have, either as single agent or in combination with other chemotherapy. And that's led to a second drug, olverembatinib, which is being tested in the late stages for CML, also being active in this drug. So this drug was updated at ASH. And again, for my pharma colleagues here, this is my usual plea, don't forget about the rare diseases, because they're diseases to the patients and the families and the spouses who have them, and we've had quite a bit of success actually in drug development going all the way. For the looking forward to this year, what I'm most excited about is the targeted therapy era in MPNs has finally arrived. I mentioned the JAK inhibitors hit the wild type pathway, so JAK-STAT pathway, but we've never had a mutant selective or specific approach. 2 trials which have just opened the doors to phase 1 enrollment. This is the AJAX study, which is a type 2 JAK inhibitor, kind of hitting the inactive conformation of the JAK, so that's just started. And then with Insight, we have the mutant-specific JAK2 V617F oral agent also just going into phase 1. Obviously, these will be in the relapse refractory setting, and we're eager to see those results. And not to be left out is CALR, the second most common. So JAK2 is the most common, CALR is the second most common driver mutation, MIPL is the third. Because the mutant traffics to from the nucleus to the surface, it's amenable to neoepitope presentation and immune attack. This has opened up a huge new area. Vaccines have already been tried and tested in phase 1. Now we've moved on to monoclonal antibody, which is open and available through Insight, the mutant CALR by CD3 bispecific, which I'm involved in with J&J. And then there's preclinical work for CAR-T, the first ever CAR-T in the MPN field directed against CALR from our European colleagues. And so, ladies and gentlemen, I leave you with this chronic disease that many of you may have forgotten, but please don't, because it's such an area, an active area of drug development. For the first time, drugs are being developed in our rare space and then going back into AML, MDS, and possibly even lymphoma and myeloma. I would end by saying that with this new era, we should also be engaging our FDA regulators together. Dr. Daver, Dr. Kadia, and my colleagues in AML have done this nicely. And maybe, as Dr. Hagemeister pointed out in an earlier trial, maybe we should be making overall survival, EFS, PFS as our endpoints, rather than spleen and symptoms, which serve their purpose in the JAK inhibitor monotherapy. But as you're seeing here now, we have non-JAK inhibitor drugs, we have people who are dying in 2 years, and we have to be able to capture the benefits of good drugs rather than killing them prematurely. Thank you very much.
Thank you, Dr. Pemmaraju. And I'd like to next welcome Dr. Daver, who will be talking to us about AML. Please welcome him to the stage.
right, well, thank you very, very much. Dr. Pemmaraju is a huge fan of Dr. Osler. In fact, yesterday he said his dream dinner would be to have Dr. Osler in attendance. I'm like, I don't know what kind of party that'd be, but okay, that's your thing. I party differently, but go for it. So AML actually, has been a disease that has seen a lot of progress. We're catching up with myeloma and drug approvals, but not in survival yet. But I think that will come soon. And it's kind of difficult to give an overview of all of acute myeloid leukemia in one 10 to 15-minute presentation. So I'm going to focus really on targeted therapies. Fortunately and unfortunately, unlike lymphoma, myeloma, CLL, ALL, we have not had the plethora of immunotherapies. I don't think it doesn't mean that we will not have them. I think it's just going to take longer. And a lot of this is because the biology of AML is highly multiclonal, highly heterogeneous. It's really multiple cancers in one, and you're just targeting that first clone that is kind of the tip of the iceberg. So immunotherapies, I think, will have to be more evolved, more thought out than what we do currently with single antigen CAR or bispecific. So we have found success in that angle with the targeted therapies, so FLT3 inhibitors, IDH inhibitors, menin inhibitors, and I think this is going to continue with other targeted therapies, which will at least improve the duration of remissions, the event-free survival, the quality of life, transfusion improvements. We may not get curative outcomes, but if we can get, like myeloma, median survival that's gone from 3 years in 2000 to 15 years in 2023, then I think that would be success in my mind. So talking about the targeted therapies, I think the FLT3 inhibitors have really paved the way for this, not just in AML, but across many heme malignancies. This is kind of a major targeted therapy group. Somebody asked me today morning when I was getting coffee, what happened to FLT1 and FLT2? That's a good question. So if anybody can answer that, will probably be a millionaire, but I do not know. Combinations are absolutely required from the beginning to target the FLT3, but also to suppress other clones that may actually be pre-existing clones such as NPM1, TET2, IDH, and others. And that's kind of how the field has evolved. So we saw limited success with single-agent FLT3 inhibitors, especially the earlier ones like midostaurin and sorafenib. We moved very quickly to combination approaches in the frontline setting. These are two randomized studies called the RATIFY study and the Quantum First. Both of them looked at intensive chemo backbone, 7+3 anthracycline cytarabine, which has been a standard for about 3 to 4 decades. And we added to that the FLT3 inhibitor on one arm, the placebo on the other arm. And both these studies showed that the addition of FLT3 inhibitor in FLT3 mutated AML improves survival to the backbone of intensive chemo. So the question now that is being asked a lot is, which of these should I choose? There's no randomized data head-to-head. The myeloma speaker said, we shouldn't do cross-trial comparison, but I love to. I agree with him. We have to do cross-trial comparisons because we have no choice. We're not going to have every trial for the 500 questions we have. And I think looking at the data with quizartinib as a single agent, which actually was led and championed by Dr. Cortez when he was with us at MD Anderson, looking at its efficacy preclinically as well as its better tolerability, and now the frontline data suggesting, at least in ITD patients, it's giving us a better 4-year survival. We are using quizartinib, and most centers in the US have moved to quizartinib in the frontline setting for the ITD. Now, if you have a TKD, remember, quizartinib will not work. Midostaurin is reasonable. Now, what about those above 60? I don't think intensive chemo is the way to go there. We have moved heavily towards lower intensity backbones such as HMA, venetoclax. I'll talk about that a little bit, cladribine, low-dose Ven. And even in this randomized study, which is a very recent study, it was actually done between 2017 and 2021, you can see that above 60, even adding a TCAD to intensive chemo, median survival is 14 months with a lot of toxicity, early mortality. So I would say to MD Anderson, and I know many big centers, above 65, we are really avoiding intensive chemo unless they have a core binding factor or something very, very sensitive to intensive chemo. And I think that may even be above 60 now, given some of this data. So one of the updates from ASH year was looking at the baseline molecular mutation profiles in the Quantum First study, which is the quizartinib randomized study of 7+3 quizartinib versus 7+3 placebo. This was presented by Mark Levis. And what they found was actually quite interesting, that there are certain co-mutations among the FLT3 ITD mutated, of all of these were FLT3 ITD mutated to get on the study, that predicted for a better response, EFS, OS. These were NPM1, DNMT3A, and TET2. Now, in most of the others as well, quizartinib seems to have some degree of benefit, but not as striking as these 3 mutations. And they showed this for survival, that those who had an NPM1 or a DNMT3A among those FLT3 ITD had quite a significant survival benefit with quizartinib in terms of overall survival. And in fact, the trifecta of these mutations, so if you have NPM1, DNMT3A, and FLT3 together, seems to really benefit from quizartinib. Now, this is really interesting biologically because historically, this trifecta was associated with very poor outcomes to OS. So if you had the triple mutation, you actually did worse than those who had FLT3 without NPM1, DNMT3A. In this setting, it's actually not neutralizing, it's actually showing a sensitization. So this group seems to really benefit a lot from quizartinib-based therapy. As you can see, there's a 30 to 40% survival difference at 3 years, and for sure, we should be giving these people FLT3 inhibitors. We should be giving it to everybody with FLT3 ITD. Now, there's also data coming out about transplant and the role of transplant. I would say in AML today, for FLT3 ITD mutated, we are still transplanting all our patients in the first remission. And I say today because there is data that has come out from UK, and we're looking at this at MD Anderson as well as in the US in a cooperative effort, suggesting that MRD, especially using NPM1 or FLT3 specific molecular NGS MRD, may predict patients who may not go to transplant. But it's very early data, and today we have not shifted our practice. We still go to transplant. This was the data from the Quantum First showing that transplant still had a survival benefit even in the era of the addition of a targeted therapy. Both independently give you a survival benefit, so one is not replacing the other. Now, you got your patient into a remission. Let's say you gave him intensive chemo quizartinib. Things have gone well. They've got to transplant. Wonderful. Dr. Alusi is ready there. He'll transplant him right away after cycle 2. Well done. Now you're here, day 50 post-transplant, patient looks good, engrafted, he's on some azoles, feels very well. What do? So maintenance now has become a critical part of the treatment armamentarium in AML, as it has been in ALL and myeloma. And for FLT3, in fact, all of the drugs are recommended by NCCN. This is the NCCN guidelines that I've pasted here to be used as maintenance, or often midostaurin, gilteritinib, quizartinib. The best data, though, I would say post-transplant for maintenance, randomized phase 3, the only one that has done a randomized study in the post-transplant setting is the Morpho study, where they clearly showed gilteritinib improved the EFS post-transplant compared to placebo in those who are FLT3 molecular MRD positive. Whenever I give this talk, people email me later and say, I have a patient, flow MRD negative, what should I do? None of this is based on flow MRD. I do not feel comfortable making any of these decisions on flow MRD. The molecular MRD that we use, this is called the in vivo scribe, there's other commercial labs that do it, can go down to 10 raised to minus 6. So it's almost 2 to 3 logs below flow. So we're talking about a very ultra-sensitive test if one is to make some decisions. Then what do you do if you cannot get this test? Today, I would give them maintenance. If I do not know if I can get this test, I would err on the side of giving the maintenance, which gave you a 80% 4-year EFS. But I think more and more we're getting access to this molecular MRD. So we're making a lot of progress in young patients with FLT3. Just about 15 years ago, the expected survival for this population was 25%. This was published by many groups, including ours. Today, we published our most recent update, and it's about 65 to 70%. So quite a major improvement in the 5-year survival. There's also data now coming out that maybe we pigeonhole these drugs into FLT3 targeted therapy, because that's like how humans like to think. You have a target, you have a targeted therapy, but there may be efficacy beyond them. So this study I find quite fascinating, called the Kiwi study. This was done out of Spain, where they used quizartinib in combination intensive chemo in the FLT3 non-mutated patients. Again, actually something that Dr. Cortez had shown in JCO almost 12 years ago as a single agent, that there are responses in wild type. They took it to a frontline randomized study. The updated data shows clearly improvement in OS and EFS. This has now led to a very large study called the Quantum Wild study, 250 centers, 800 patient study that is going to see if quizartinib works, not just in the FLT3 mutated, where we know it works and is approved, but also in the wild type. And there's also a signature that has been developed using RNA sequencing. So this may be very similar to the Philadelphia-like signature. There's a FLT3-like signature. So I'll wait to hear more about this in the near future. Now, what about those people above 65, and I would say maybe even above 60, 65, where I'm nervous to give intensive chemo, maybe some frailty, maybe some comorbidities, maybe some cardiac liver issues. So HMA-VEN, is a poor standard in the FLT3 ITD, I would say. When you look at this lower right curve, that is the curve that was published by Marina Konopleva from the Viale-A AZA-VEN outcomes with FLT3, and in fact, you can see the median survival is actually quite low. In the FLT3 ITD, it was even lower. It was 10 months. The aggregate was about 12 to 13 months. So we then said, well, why should we only use aza-ven? You have targeted therapies like gilteritinib, quizartinib. Can we find a way to safely add those and optimize the doses? This led to the aza-ven gilteritinib study that Nick Short and our group has been working on. This was the publication exactly a year ago, last January in JCO, showing high efficacy, 95% remission, majority of them full CR, which is very important to note, full count recovery with a deep molecular MRD negativity and an OS with about an 18-month follow-up that was not reached. Nick updated this data at ASH, where we actually pooled our frontline triplets, aza-ven gilt and aza-ven quiz, and we're actually now starting to see that there is a median survival here, but it's actually quite good, 38-month median survival, and I put below in the box the numbers that were seen with VIALE-A. So the expected median OS from VIALE-A with aza-ven was 11.5 months. Here it is looking at 38 months, and if you look at the ITD alone, it was about 9.9 months. Here it is 28 months. So I think this is probably the way to go, but it's still not curing patients, so we may still need to continue to evolve on this in the future. And here, just looking at the various regimens, this triplet is probably the one showing the best activity. I'm going to move quickly here a little bit to the menin inhibitors. So this is another area that has emerged, much more recent than FLT3, just in the last 3 to 4 years. I think many of you may know, but if you don't, KMT2A is a very, very high-risk subset. So after TP53 and MECOM, historically, KMT2A rearranged AML has had the poor outcome. You can see here median survival less than 3 months in the salvage setting. Almost no patients make it beyond a year. It's about 8 to 10% of relapse AML, more common in the younger population, so reasonable subset. Relapse NPM1, when we started doing this, the FDA said, well, relapse NPM1, the bar is higher, the outcome should be better, everybody says it's favorable. So we actually did this analysis, Dr. Issa, myself, and others, to look at outcomes in relapse NPM1 at MD Anderson, 200 patients with the mutation versus 1,500 without. And guess what? In relapse NPM1, there's nothing favorable. Relapse AML is not favorable in any setting. The median survival in relapse NPM1 is 5 to 6 months, the same as those without the mutation. And this should be considered a population of pretty much equal unmet need, in my view, as the KMT2A. So this has led to now a plethora of menin inhibitors. With the FLT3, took us 10 years to get 3 FLT3 inhibitors. Here, within 3 years, we already have 4 menin inhibitors, all of them actually showing efficacy. There are differences in them in terms of the pharmacology as well as the kinetics, the half-life, the binding, and the safety, especially differentiation syndrome, QTC, are quite different among the different drugs. Efficacy, I'm not yet sure if we're going to see differences. They look similar in terms of CR/CRh. Revumenib is the only one that's approved. This was approved very recently, October of 2024. This was the update of the approval study, the augment study looking at relapse refractory KMT2A. It's only approved right now for KMT2A. The relapse refractory NPM1 data was just released December, and hopefully we'll also get to approval in relapse refractory NPM1 in a few months. CR/CRh rate, about 25%. CRC rate, which to me is more important, and to Dr. Alusi is more important, mean I've achieved a marrow remission with some count recovery, I can move to transplant, was actually pretty good, 40-45%. But we do see differentiation syndrome manageable with revumenib. I say it's quite a manageable differentiation as compared to maybe Zift or Blexi, but the QTC effect is specific to revumenib and something we have to take into account. We don't see this with other menin inhibitors, and if you're adding azoles, quinolone, Zofran, you have to be careful about the QTC with revumenib. But all in all, I think quite a good drug, approved and will be used a lot in the salvage setting. Bleximenib is another menin inhibitor, came more recently. I'm not going to spend a huge amount of time. It's a little earlier. We don't have as much robust phase 2 data. The phase 2 actually has started. The big difference here is the differentiation syndrome with Blexi is more powerful. There were fatalities. There was an FDA hold because of this. There is a more ramp-up dosing, earlier use of steroids, and prophylaxis. I think it's manageable, but that will be something to look out for if it gets approved in the future and gets into the community. CR/CRh rate actually quite similar, as you can see, about 30%, with the composite CR also very similar, 40 to 45%, does not have a QT effect, which is good. And the newest player on the block is enzomenib, a drug. We've been working on all of these in MD Anderson. Enzomenib is kind of the more recent one. And I have to say the safety profile has been very, very encouraging. We've now treated 85 or so patients, no DLT. We have not seen any grade 4 DS, mortality, discontinuation, and the QTC does not seem to be in effect. And it actually has a very short half-life, which I think will become important as we move into the combinations and may help us titrate the doses more tightly. The efficacy, Many people at ASH get excited, and we've had hundreds of discussions on this. Is it better? I don't know. I think it's equal to slightly better. We have to get more numbers, but we are seeing close to 35-40% CR/CRHs, but I think the data in the combination will be most important. All three of these are now in pivotal phase 2 studies. And lastly, I'll just mention, again, like the FLT3 story and the IDH story, single agent, it's going to give you 30, 35, 40, whatever number you want to use, but it's not going to give you 70, 80% response. Here, the combinations will come into play very much like what the myeloma ALL colleagues have done. Gus Issa and our group has started building combinations. This is a safe, steady oral decitabine HMA ven revumenib, and we're seeing now close to 80% remission rate, CRC rates of 60%, and we have to get more follow-up, but I think the survival will also look better than what we've seen with the single agents. And then lastly, I'll just mention IDH. There hasn't been as much, but the frontline data with the triplet that Dr. Leonardo and our group has been working on, AZA-VEN IDH, very similar to the AZA-VEN GILT that Nick, myself, and others have worked on, is looking very, very good, especially in the newly diagnosed non-therapy-related AML. The triple therapy is giving us now 3-year survival of 90%. So this may be a way to go for IDH as well, the combinations, and many of these have now gone into randomized studies in Europe and other areas. So I think in conclusion, we have definitely made progress. FLT3 survival has improved. I think we'll see KMT2A IDH also improve dramatically, but there are many subsets like TP53-MECOM for which we still have unmet need, a lot of efforts ongoing. Some have failed, but we will keep trying, and I think immunotherapies will eventually play a role in that. So hopefully we will talk more when we have the dinner with Dr. Osler in a few years. Thank you very much.
Thank you very much, Dr. Dauber. Okay, folks, we have another break now for lunch. So go ahead to the room, grab some lunch, and work your way back over here. We're going to be getting ready for the Pfizer session, looking at outpatient care of patients with myeloma.